Bangalore. Uh, he is there since 2005, the last 17 years, and he did his Bachelor of Medicine and Doctor of Medicine in Rehabilitation Medicine from the SMS Medical College, and he has been specialized. He has specialized in use of yoga techniques, pranayama in rehabilitation, especially with the neurological disorders. So, with this, I request our technician to play the recorded video message lecture of Dr. Gupta.
Good evening, everybody. I am Dr. Anupam Gupta, working as professor, ex-head, Department of Neurological Rehabilitation, National Institute of Mental Health and Neuroscience, popularly known as NIMHANS, from Bangalore. And at the outset, I would like to thank Dr. Datta for inviting me for this talk. My topic is yoga and pranayama in neurological rehabilitation. So I have limited research experience in the field of yoga and pranayama, but I am myself is an enthusiast who performs yoga and pranayama most of the days of the week. So that's how I have got my interest in yoga and pranayama. So let's start the talk. Yeah, so this is the our building, 16 years old building of neurological rehabilitation, and we share this building with the Department of Psychiatric Rehabilitation Services. Right, so outline of my presentation. I believe you guys know more about yoga and pranayama. So the first part of the talk, I'll be just talking briefly about what is disability and what is neurological rehabilitation, the magnitude of neurological disorders in the world and in the country, the conditions which require rehabilitation or neurorehabilitation, how it is done, who are the people who do neurological rehabilitation and types of neurological rehabilitation. Second part of my talk would be talking about the yoga and pranayama. So we'll be talking about the types of yoga and pranayama and their neurophysiological effects. And then the last and the most important part of the talk would be focusing on the yoga and pranayama and neurological rehabilitation. What is the current scientific evidence? And then we will conclude our talk. So what is rehabilitation? Well, the plain and simple definition of rehabilitation, it's a process of helping a person to reach the fullest physical, psychological, social, vocational, avocational, and educational potential consistent with his or her physiological or anatomical impairment, environmental limitations, desires, and life plans. Well, it's an interesting observation. Neurological damage is present in 40% of the patients having severe disability. So any disability, 40% of these patients who are having severe disability have neurological damage. And majority patients with complex disabilities have a combination, not only physical, which is sensory, motor, and other issues, but cognitive and behavioral impairments also. So neurological rehabilitation pursues restoration of function as well as facilitation of compensatory or adaptive strategies in any types of disability. As you know, active rehabilitation part is restitution, substitution, and then the compensatory strategies. So all these are part of neurological rehabilitation. And the process, it involves a multidisciplinary and multi-professional team and is highly dependent on the interaction of multiple treatment agents and factors. If you look at the magnitude of the problem or the prevalence of neurological disorders, more than 1 billion population out of 7.5 billion population in the world has neurological disorders, with 6.8 million people dying out of neurological disorders. And there are changing trends in the last 2 decades with highest disability adjusted life years in stroke, dementia, febrile convulsions, and epilepsy. In India, the prevalence of neurological disorders is close to 3,000 per 1 lakh population, but it excludes trauma and infections. So 30 million persons with neurological disorders in the country, in our country, and close to 80% of the patients with neurological disorder would have disability at 6 months, and 60% of them will have disability at 1 year. So what is the spectrum of disability? We know the spectrum of disability is impairment, disability, and handicap. What is impairment? It is any impairment is loss of anatomical or physiological function in the body. Impairment, just like a person who is having hemiplegia. So right side of the body is not working is patient's impairment. Because of this impairment, person is not able to perform certain activities, not able to use the affected hand, not able to walk because of hemiplegia is its disability. And what is a handicap? At the level of society, what he or she is not able to do because of this hemiplegia, is not able to go to office, not able to do the task expected of him or her, is known as the handicap. So same illness, neurological illness, at the level of organ is impairment, individual is disability, and societal level it is handicap. Same thing about the international classification of functioning, disability, and health. As you can see, health condition, disease or disorder, it will have involvement of bodily functions and structures, impairment, activity limitation, which is disability, participation restriction, and then it's certain factors influence these, like environmental factors, personal factors, and contextual factors. So this is the ICF classification of functioning, disability, and health. What are the categories of patients who require neurological rehabilitation? Well, you may believe certain patients who are having certain neurological illness may not require rehabilitation, but we have to understand majority of neurological illness patient would require neurological rehabilitation. Take the example of patients with mild stroke. Patients of Guillain-Barré syndrome, we believe more than 80% of the patients of Guillain-Barré syndrome recover completely. But still during that recovery phase where they take 5, 10, 15, 20 days, patients would be requiring short-term rehabilitation. Patients showing improvement steadily with partial or full functional recovery, like patients who are having moderate stroke, patients having traumatic brain injury or encephalitis. So the patients are showing improvement, but they have a lot of residual disability and would be requiring rehabilitation. Similarly, patients who are having partial recovery only and expected to have residual disability. Again, taking the same example, like patients who are having severe stroke. So we know that most of the patients, 3/5 of the patients who are not able to use their hands post-stroke. So they have severe stroke. And so do you have to rehabilitate these patients for long-term? Brain injury patients, moderate to severe traumatic brain injuries or encephalitis, these patients would have a lot of disability and would require long-term neurological rehabilitation. Patients who are having degenerative disorders or remitting relapsing course, again, so they would be requiring long-term rehabilitation, like patients of dementia, who would initially require neuropsych rehabilitation, but later on, once the patient develop sensory motor deficits, also bladder bowel involvement, so these patients would require rehabilitation. Patients with multiple sclerosis who are having remitting relapsing course, and eventually once the degenerative phase sets in, all of them would have progressive multiple sclerosis. So all these patients would require long-term rehabilitation. Parkinson's disease, especially late Parkinson, once the effect of levo plus carbidopa is waning off, patients start having motor fluctuations and autonomic dysfunction, cognitive issues. So all those patients would be requiring long-term rehabilitation. Patients who are having muscular dystrophies, which are known to be insidious onset and gradually progressive illnesses, and there is no cure. So you have to rely on long-term rehabilitation strategies. And then the patients who are having very rapid progression of illness, like motor neuron disease, where the patient is going to live for 6 to 9 years, and they would have rapid progression in their disability, or patients with malignant tumors. So all these patients would require long-term rehabilitation. And we have seen patients in our ward, say glioblastoma patient operated post-surgery developing hemiplegia, staying with us, and we teach them. Patients start walking, start using the affected hand, aphasia recovering, and then there is a recurrence of tumor, and then all the hard work goes down the drain, and patients again develop symptoms. So all these patients would require neurological rehabilitation. So what is the process of neurological rehabilitation? How is it different from a medical treatment? So once the patient comes into your OPD, you have to assess the patient and assess the rehabilitation potential. What is the potential of recovery and what domains you are expecting the patient is going to show recovery. So that is important. Then accordingly, you make a rehabilitation aims. What are the aims? What are you planning to do? and which members of the team would be involved in the rehabilitation of a particular patient. You are making a customized program for the patient. Then you set interim goals. Of course, you see the patient has come to you spinal cord injury, already showing good recovery or moderate recovery. Patient is going to take time, 4 to 6 weeks, and then in those time you have to just teach the patient hand skills, walking, bladder, bowel, other issues. So you cannot you cannot jump the gun and talk about what is the eventual outcome of the patient. You have to make interim goals. This week we will start this program. Let's see how patient responds. So you make interim goals, review the patient. You have achieved the goal, go to the next goal. Like that, you have to make interim goals. Then you decide the therapy. What kind of therapies patient would be required? Patient is responding only to medication, or patient would be requiring splints, would be requiring intervention from therapists, physiotherapists, occupational therapists, orthotists, social workers, psychologists, like that. Then you reassess and review the goals, and then you follow up the patient. So this is the whole process of doing the rehabilitation of the patients. And what are the rehab domains? Of course, you should know the natural history of illness. A patient coming to you with Guillain-Barré syndrome, or patient who's coming to you with stroke. So you have to just convince the patient first, like you are GBS. So natural history suggests more than 80% chances you are going to improve, you are going to do better. May not be immediately, but after some time, but you will improve. Or a patient who's developing a stroke, the patient is showing good signs, already hand movements are there, finger movements are there. So you should know the natural history of illnesses. Neurological status, detailed clinical examination is very important. And then you have to look for the domains which you are going to address in a patient who's having disability because of neurological disorders, like what is the ambulatory status of the patient, activities of daily living, what he or she is able to or not able to perform, bladder involvement, bowel involvement, psychological issues, vocational issues, sexual issues. So all these issues are the domains which you need to address in order to provide a comprehensive rehabilitation to the patient. And then you can't do it alone. You need to have a comprehensive team, a complete team, multidisciplinary or interdisciplinary team to impart the training to the patients, of course, which would include a rehab physician. Then you would require occupational therapists, physiotherapists, orthotists, social workers, speech pathologists, clinical psychologists. So more comprehensive team you have got, so more are the chances you will be able to address most of the domains of disability in a particular patient. Where can you offer the rehabilitation? What are the sites of rehabilitation? You can offer rehabilitation as inpatient facility. Nowadays, acute care facility rehabilitation has become very trendy. Patients who are comatose, tracheostomized are usually referred, once they are hemodynamically stable, are referred to the special units, and they are provided rehabilitation care. Or patient is taken to a dedicated rehabilitation center like ours once the patient is stable, and then we make a program and provide rehabilitation. Or the skilled nursing facility on inpatient basis. Outpatient basis where you can offer rehabilitation hospital based or day hospital setting, or in the home setting also you can offer rehabilitation. Then coming to the second part, now we know what is rehabilitation, what is disability. Then coming to the second part of the talk, which is yoga and pranayama. And I believe most of you know much more about the yoga and pranayama than we do. But let's see what we are able to discuss. So yoga, the word is derived from Sanskrit word yuj, that is to unite. So the main aim of yoga is to achieve holistic health by following the eightfold path of yoga, which includes yama, that is universal ethics for the moral and spiritual development, niyama, that is individual ethics, asanas, that is the physical postures, pranayama, that is breathing control for improvement of physiological functions, pratyahara, that is control of senses, dharana, that is concentration for making our mind alert and pointy, dhyana, that is meditation, and samadhi, that is a bliss which helps in attaining inner peace. What are the branches of yoga? It is a karma, that is path of service, raja, that is path of meditation, jnana, that is path of sage or scholar, bhakti, that is path of devotion, and tantra, that is the rituals, all the rituals. So these are the branches of yoga. What is pranayama? Well, pranayama is yogic breathing exercises. It is a form of meditation and preparation for deep meditation. How does it work, pranayama? And we will see the scientific evidence subsequently. So what does the pranayama do? Pranayama promotes physical well-being and self-awareness in either the healthy adults or the patients. It improves lung and cognitive capacities of the person and or the patients, reduces the blood pressure, reduces the anxiety, and other psychosomatic patterns. So we know there is a sympathetic tone, which is fight or flight. In the cases of emergency, you have increased cortisol level secretion, and you have to take immediate decision. And you have parasympathetic tone, where you have rest and digest. So patient just takes deep breaths, relaxes, and then tones down, the anxiety comes down, BP comes down. So that is what pranayama does with deep breathing or other methods, which we will be discussing subsequently. Increasing the parasympathetic tone so that the patient is in the resting mode more. What are the aspects of breathing according to Patanjali? These are known as the inhalation or the puraka, exhalation is the rechaka, and the retention of air is kumbhaka, and prana. Prana is the primary or the vital energy. So prana is known by different names in different cultures, like qi in Japan and chi in China. So what are the neurophysiological effects? Well, these neurophysiological effects are studied by a number of studies. And what they did, either they did the EEG at the time when the patient is doing yoga or pranayama, or they did the functional MRI, or they did the PET scan. So brain recording is there. So we have solid scientific evidence when the patients are doing different, patients or healthy adults are doing different asanas or pranayama or yoga. So what happens? What is the neurophysiological effect in the brain? And it is recorded. So these are studies taken from a review article where they had just taken a lot of studies, and they were talking about different asanas and what are their neurophysiological effects. So the first is the Bhramari pranayama. Bhramari, we know, is a vibrating, buzzing, and constant sound of the bumblebee produced by exhaling strictly through the nasal airways. And after the starting of exhalation, and this particular study, EEG was done in all the persons who were doing the Bhramari pranayama. So EEG exhibited a dramatic increase in the power of high frequency waves, which is due to the appearance of a particular pattern of EEG activity, predominantly in the left middle temporal lobe, known as the paroxysmal gamma wave, and it represents the non-epileptic hypersynchrony. Stop signal reaction time, which estimates the ability to suppress motor response, which is very important cognitive function. So what did they observe? Before and after deep breathing and Bhramari, and what this particular study reported, this results indicated a significant reduction in stop signal reaction time only for Bhramari, suggesting that the practice enhances the response inhibition, which is considered to be cognitive function controlled by the dorsolateral prefrontal cortex, or a flexible cognitive control. Then Mukh Bhastrika, which is described as having the breath actively blasted out in multiple whooshes with forcible abdominal contractions, and it produces an immediate reduction in both the visual and auditory reaction time. So which indicates improvement in the sensory motor performance. So how does it work? The hypothesis is that the afferent inputs from the abdominal and thoracic organs, when you are doing forceful abdominal contractions, they modulate the ascending reticular activating system, which is responsible for the activation state. We know the reticular activating system injury causes the coma or vegetative state kind of picture in the patients who are having head injury or injury to this particular area system. So it modulates the ascending reticular activating system and its connections to thalamus and then to cortex. So this modulation has some positive effect. So which improves the sensory motor performance of the healthy adults or the patients, and improves the general arousal also. Then Sukh Pranayama. What is Sukh Pranayama? Sukh Pranayama is basically conscious slow breathing done regularly through nostrils, deep inhalation followed by deep exhalation. So this particular study was done by Mobini Bigdoli and et al. And the patients who were scheduled for coronary angioplasty, just before that, the patients were given Sukh Pranayama, and they were divided into groups. So patients who were given Sukh Pranayama and the other patients who were not. So what did the authors observe? The patients who are doing Sukh Pranayama or deep breathing, inhalation, exhalation exercise, their anxiety level came down multiple times as compared to the control group. So patients were much more relaxed and calm at the time just before going for major procedure or the coronary angioplasty. Then mind wandering, which is a very common phenomena when we do the meditation. We commonly see it at the time of doing meditation. And it is reported during focused attention meditation. So in a non-advanced practitioner experiment, a dynamic fluctuation between states such as the mind wandering, awareness of mind wandering, aware or shifting the focus back towards the breathing, which is shift, and attention focus on the breath was studied. And what did the authors observe? Authors observed that during the mind wandering phase, activity in the posterior cingulate gyrus, which is a part of medial cortex, posterior cingulate cortex, middle prefrontal cortex, and posterior parietal and temporal cortex and parahippocampal gyrus were detected. So activities were noted in a wide area of brain at the time of mind wandering. Then when the patient has the awareness, he or she is losing focus. So this aware phase revealed robust activation in bilateral anterior insula, which is a lateral part of the cortex, and dorsal part of the anterior cingulate gyrus. So these are the brain regions associated with conflict monitoring and self-regulation. Then during the shift phase, when patient is trying to bring back the focus after the mind wandering, significant activation was observed in the lateral prefrontal cortex, both dorsal and ventral part. When we know that dorsal prefrontal cortex is responsible for a lot of executive functions, and lateral inferior parietal cortex with more robust activation in the right hemisphere. Then during the focus phase, when the patient is again, or patient or person is again focusing attention on the breathing, there was a cluster in dorsolateral prefrontal region and a lack of activation in parietal elements of the executive network. So these were some of the interesting findings reported by this particular study done by Hazenkamp et al. Then what happens with Kapalbhati? So this particular study was from India, done by Dr. Pradhan et al. And an active exhalation by a rapid contraction of abdominal muscles with passive inhalation. So this particular study reported no improvement in motor skills or attention of the participants who performed Kapalbhati. Then right unilateral nostril breathing, Anulom Vilom, like we do. So it can improve attention and language as well as decrease anxiety and depression in post-stroke patients. So this particular study was done not with healthy adults, but on the patients who were having stroke survivors. So what did they observe? There was improvement in several metrics of anxiety and language, and after 4 weeks of guided meditation or breathing practice, but which was not sustained till 10 weeks. So if you discontinue the practice and use the outcome measures after discontinuing the Anulom Vilom or the unilateral nostril breathing, you would lose the positive effects. So what did the authors conclude? They concluded that unilateral nostril breathing may be a low-cost prospective complementary technique which needs extended period of guidance to improve effective, that is both mood as well as the linguistic abilities. So it will not have long-lasting effects. You have to keep doing it in order to have a beneficial effect of this particular practice. Then the neural mechanism of attention to breathe, which is in emotional regulation, was studied. And this particular study, what did they observe? Attention to breathe decreases the amygdala. Amygdala is a part of limbic system, which is responsible for the emotion and memory part, and emotions of the memory also. Activation while increasing the integration between the amygdala and the prefrontal cortex during the adverse emotions. An increase in emotion-related functional connectivity was found between the right amygdala and the left prefrontal and cingulate areas during the attention to breathe. Then Bahir Kumbhaka, this particular study, in fact, it is two studies were done by Nivedita et al. And Bahir Kumbhaka, they reported, Bahir Kumbhaka, or the pause after expiration, changes the cerebrovascular hemodynamics by increasing the parasympathetic activity, in contrast to Kapalbhati, which increases the sympathetic activities. And Antar Kumbhaka, that is air in retention after inspiration, may produce hypercapnia. So hypercapnia is what increase serum level of carbon dioxide, leads to vasodilation and increase in cerebral blood flow. Whereas Bhastrika Pranayama, which is described as forceful inhalation and exhalation, on the contrary, it reduces the cerebral blood flow and increases the heart rate and blood pressure. So that sympathetic effects it is producing and reducing the carbon dioxide levels. So these are some of the studies which reported neurophysiological effects of different asanas or pranayamas or the yoga. Then coming to the last and the most important part of the talk, what is the current evidence? How does it work, yoga and pranayama, in a neurological rehabilitation setup or any rehabilitation setup? So most of the studies I have taken are done with the patients who are having some neurological disorders, but 1 or 2 studies are taken where they were done with the healthy adults. So let's see how strong is the scientific evidence of yoga and pranayama. So this is the first study. I'm taking my own study. We published this study 10 years ago in disability and rehabilitation. And this particular study was done in patients with Guillain-Barré syndrome. So we observed the effect of pranayama and meditation as an add-on therapy to rehabilitation in patients of Guillain-Barré. It was a randomized controlled trial, and we included 22 patients who were relatively young. The mean age was 32 years in the yoga group, and the control group age was 31 years. Male is to female ratio, as you can see, 2 patients could not complete. So in the final analysis, only 20 patients were included. So 8:2 ratio, male female in the yoga group, and the control group, it was equal ratio, right? So intervention group ko we gave yoga plus the routine PT and OT program, and control group ko we gave only PT and OT and no yoga. We gave 15 sessions to these patients, each session of 1 hour, 5 to 6 sessions in a week in the evening, when the patients have done all their activities of the day, and then they were invited for this particular yoga session. And what were the practices given to the patients? Pranayama, a lot of pranayama like Vibhagya pranayama, Ujjayi pranayama, Shitali pranayama, Sitkari, Sadanta, and Brahmari pranayama. 5 minutes, all these pranayamas were taught to the patients. Then the quick relaxation technique, when the patient is just taking a quick fist and releasing the muscles, or mind sound resonance technique. So these yoga pranayama were taught to all the patients. What were the outcome measures? We assessed their sleep quality index using the Pittsburgh Sleep Quality Index, numeric pain rating scale, because we know Guillain-Barré patients, especially those who are coming to rehabilitation for inpatient rehabilitation, they belong to a group where they are unlikely to recover completely. They will have some residual deficit, and these patients have a lot of neuropathic pain complaints. So numeric pain rating scale was used. Then hospital anxiety and depression scale was used to assess their anxiety and depression and their disability using the Barthel Index score. What did we observe? Well, at the end of the study, you can see in the yoga group, the patients showed significant improvement in their sleep quality, improvement in their pain, significant, again, statistically significant at least, and anxiety and depression, and Barthel Index. So all domains or outcome measures showed statistically significant improvement at the end of the study. Whereas in the control group, still patients showed significant improvement in their anxiety and depression level, as well as in their disability level using the Barthel Index scores. But between the group comparison, when you compared the yoga group with the control group, we observed the only significant improvement was there in the sleep quality. So the patients who were doing yoga were getting much better sleep as compared to the control group patients. Then the effect of diaphragmatic breathing on attention, negative effect, and stress in healthy adults. So this particular study was performed on healthy adults, and effect of diaphragmatic breathing. So this study included 40 healthy adults, and they were randomized into diaphragmatic breathing and resting breathing. So they were offered 20 sessions over a period of 8 weeks, and each session had 15 minutes of diaphragmatic breathing and 15 minutes of resting breathing in the intervention group. And the outcome measures were positive and negative effect schedules, number cancellation, which is used for assessment of attention tasks. So number cancellation test, and the serum cortisol level, which suggests the level of stress. So if you see the results of this particular study, the patients in the intervention group showed much better control of respiration. So their they started doing deep breathing exercises. So their respiratory frequency came down with the training. Negative effect to assess the patient's mood. As you can see in the intervention group, which is the solid line, whereas control group has the dotted line, the intervention group में, comparing to the first session and the last session, there was statistically significant improvement in their mood. So it improved their mood also with the diaphragmatic breathing. And this is the number cancellation test. As you can see in this graph, first session versus last session, the scores in the intervention group improved significantly as compared to control group with diaphragmatic breathing. And lastly, if you look at the serum cortisol level in the intervention group, on the first day, cortisol levels were high as compared to the control group. But by the time of the last session, the cortisol level came significantly down in the intervention group, or the patients or the healthy adults who did the diaphragmatic breathing. So cortisol levels came significantly down with this diaphragmatic breathing. So diaphragmatic breathing has impact on healthy adults also. Then this is again another Indian study published in 2019, the efficacy of yoga as an add-on therapy to physiotherapy in the management of patients with paraplegia. It was again a randomized control trial with a very good sample size. As we will see, it included 124 spinal cord injury patients who had were motor incomplete. Asia impairment scale C and D suggests motor incomplete. Asia A and B are sensory motor complete and sensory incomplete A and B, but C and D are incomplete motor spinal cord injuries. Intervention group 62 patients, control group 62 patients, and mean age of the patients were very young, 33 years of age, 32 years of age in the control group. Intervention group got 75 minutes of yoga therapy every day for 6 days per week, and assessment was done at day 1 and after day 30. So these were the practices of pranayama or yoga were given to the patients. Loosening practice, that is sukshma vyayama of upper limb, moving the fingers, moving the wrist, moving the elbow, moving the shoulder. Then sukshma vyayama in the lower limb by doing the toe movements, ankle movements, knee movements, and hip movements for 5 minutes. And then they were offered asanas. Asanas were padhastasanas or ardha chakrasana or adhkati chakrasana or the vakrasana. And then the kriya was kapalbhati. Kapalbhati was, and all these exercise, pranayama and asanas were offered to them for 2 minutes each. Then the pranayama. Pranayama included vibhagya pranayama, nadi shuddhi, brahmari, and bhastrika. And lastly, relaxation practice by doing the deep relaxation technique or mind sound resonance techniques. So the total duration of 75 minutes per day yoga. The primary outcome measures were C-reactive protein. C-reactive protein is inflammatory marker. So just to see what the level of C-reactive protein, the effect of yoga and pranayama on the C-reactive protein or the inflammatory marker in the blood. Spinal cord independence measure, which is the most commonly used disability index to see the patients of spinal cord injury, their improvement, functional improvement after rehabilitation. And the medical-based emotional distress scale was used to see their stress level, and Asia impairment scale, which suggests the severity of spinal cord injury. What did the authors observe? The results, I have not taken any graph, but this result showed C-reactive protein, there was significant improvement in the level. That is, it came back to the normal level in the patients who did the yoga. Skim score showed significant improvement in the intervention group as compared to the control group, and same was observed with the medical-based emotional distress scale. But Asia impairment scale in both the groups, between the group difference was not significant. Both patients in both the group performed almost same. Then yoga for multiple sclerosis, and this is a systematic review and meta-analysis published some years ago. And it included 9 articles, out of which 7 were randomized controlled trials, and 670 patients were included in this meta-analysis. And yoga versus exercise or usual care. That's how the patients were assessed. Which were the yoga offered to the patients? Hatha yoga, Iyengar yoga, asanas, dhyana, that is meditation, and pranayama. In the exercise group, patients performed aerobic exercises and resistance exercises, treadmill training, and sports climbing. So duration and frequency, these yoga and or the usual care or the exercises were given from 8 weeks to 6 months, and with the median of 10 weeks. So for 2.5 months, these patients were given these programs. The frequency was 1 to 3 times per week and 60 to 90 minutes per session. What were the outcome measures used in these studies? MS-related quality of life, fatigue severity. Fatigue we know is one of, in fact, the most commonly reported symptom by the patients, multiple sclerosis patients. So fatigue severity scale was used. Mobility was used with 10-meter walk test, that is to assess their speed. 2-minute and 6-minute walk test, which is used for endurance, how long patients can walk. And their mood was assessed with Beck's depression inventory and the profile of mood states. What were the results? As you can see, between yoga and usual care, quality of life, fatigue, mobility, and mood, between the group difference was not significant. Other than mood disorders, the yoga group showed significant elevation in the mood at the end of the study. Yoga versus exercise, there was no significant difference between the group which were doing yoga and the patients which were doing exercises. No significant difference was observed, especially in relation to multiple sclerosis patients. Then the lived experience and patient-reported benefits of yoga participation in patients who are having brain injury. So this study included 31 patients who are having traumatic brain injury or acquired brain injury. Acquired brain injury could be anything, encephalitis, it could be stroke, or it could be anything, any injury which is acquired, brain injury. So it was a mixed method, quasi-experimental design, pre-post study. Patients were given 1 session per week, 60-minute session of Hatha Yoga, breathing and meditation. And audio taped semi-structured interviews say they were asked how they felt before the session and after the session. So this is the demographic profile of the patients. You can see young patients, traumatic brain injury were less, and acquired brain injury, which included stroke, aneurysm, tumor, hypoxic ischemic injury, or encephalitis. These patients were included in this study. And what the authors observed, the patients were given 3 sessions. And then they were asked their well-being. So well-being, you can see after pre and post class 1, after the first class, patient showed significant improvement in their well-being. That's what they reported with this semi-structured interview. So there was significant improvement. In terms of relaxation, patients reported relaxation pre and post class 1 and pre and post class 3. So post the class, they reported significant relaxation in their condition, general relaxation, not elevation or alleviation of the illness, but relaxation was there. And about the satisfaction with the sessions, there was no difference found between the patients who avail class 1, class 2, and class 3. Then this study, again a recent study, 2020, yoga improves balance, mobility, and perceived occupational performance in adults with chronic brain injury. So this particular study included only brain injury patients, traumatic brain injury, not like the previous study where acquired brain injury patients were included. But its sample size was small. It included only 9 patients with a mean age of 56 years. Duration of trauma varied yoga and post yoga. And sessions, they were given 2 sessions per week, each session of 1 hour for 8 weeks. And yoga was pranayama, eye movements, and asanas. Asanas done in the sitting position, lying position, supine lying, prone lying, and standing position. And outcome measures to assess their balance, Berg's balance scale, which is probably the very commonly used scale in the rehabilitation setup. Mobility, they use 6-minute walk test, and occupational performance and satisfaction. What were the observation? As you can see, the first graph, which is talking about the Berg's balance scale, pre and post, significant improvement in the balance of these patients. Similarly, walking in 6 minutes. So their walking endurance improved significantly after the training for 8 weeks. The patient showed they were able to walk for much longer distance at the end of the study and after doing this yoga and pranayama. And their occupational performance and satisfaction, significant improvement was reported by the end of the study, as you can see in this graph. Then yoga for stroke rehabilitation. This is a Cochrane review published 5 or 6 years ago. It included 2 randomized controlled trials and 72 stroke participants, age range from 60 to 63 years, and duration of stroke was more than 4 years to 9 years. Yoga sessions, study 1 they were given 2 sessions of yoga per week for 8 weeks. Second study had 1 session per week for 10 weeks. And the outcome measures were the quality of life, balance assessed with the Burke's balance scale, and gait assessed with the comfortable gait speed test, and motor functioning with the motor assessment scale. And disability, modified Rankin scale, which we very commonly use in all our stroke patients. The results, the quality of life, a lot of components showed no difference between the patients who were doing yoga and the patients who did not perform yoga, like physical, emotional, communication, social participation, stroke recovery, no difference. But the memory domain of quality of life, the yoga group suggested statistically significant improvement. Balance, there was no improvement between the groups in both the studies. Motor function, again, not significant difference between both the groups in both the studies. And disability, there was no significant difference at the end of the study between the groups. So what did the authors conclude? Authors concluded that yoga has the potential for being inducted as part of patient-centered stroke rehabilitation, although most of the domains did not show any difference between the groups. Then dementia. Nowadays, a lot of patients are reporting to the geriatric clinic, and patients not only with Alzheimer's, frontotemporal dementia, but patients who are having Parkinsonian disorders and other disorders with the cognitive impairments are there. So this particular study observed the effects of yoga on patients with mild cognitive impairment, that is early dementia, or they're having full-fledged dementia. So it was a scoping review. They included 8 trials, 348 patients, out of which 3 were randomized control trials and 5 were quasi-experimental designs pre-post study with no control group. And 3 trials had yoga only, whereas 5 trials had yoga was part of multi-component intervention. And what were the yogas offered to the patients? Kundalini yoga, Hatha yoga, and LVCY chair yoga. What did the authors conclude? Authors concluded that yoga may have beneficial effect on cognitive functions, particularly in attention and verbal memory. And yoga may have affect cognitive functioning through improved sleep, mood, and neural connectivity. So what did the authors report? Authors reported that not only it improves, the yoga improves the cognition, but by improving the sleep of the patients and mood of the patient, so patients perform better cognition-wise. So it has both direct impact on cognition as well as indirect effect on favorable effect on cognition by improving the sleep and mood of these patients. So, but they reported limitations also for these studies, like lack of intervention details. Intervention was not described in great length in these studies, and there was variability in frequency, duration, and components of intervention. Then yoga on your minds, a systematic review for the neuropsychiatric disorders. So this study included 16 randomized controlled trials, and the patients were effect of yoga in patients who are having neuropsychiatric disorders. What did the authors observe? They observed grade B evidence that yoga has the potential acute benefit in depression, not long-term, but acute benefit in depression, taken out of 4 randomized controlled trial. And yoga is beneficial as adjunct to pharmacotherapy in schizophrenia patients with the 3 randomized controlled trial, and in children with attention deficit hyperactivity disorder. So we had grade B evidence that yoga may work in these patients, at least in the short-term run. And there was grade C evidence that yoga has beneficial effect in persons with sleep complaints. Right? So what were the yoga offered to these patients? It was self-control, yama, self-regulation, exercises, controlled breathing, that is pranayama, controlled senses, that is pratyahara, concentration, that is dharana, meditation, and self-realization. So all these yoga and pranayama were offered to the patients, and we got this kind of evidence for the neuropsychiatric disorders. Then neuropathic pain or nociceptive pain is, especially neuropathic pain, is part and parcel of any rehabilitation setup, neurological rehabilitation. Patients with spinal cord injury, head injury, stroke, Guillain-Barré, neuropathies, patients would have neuropathic pain, and you may have to give polypharmacy to effectively control the neuropathic pain. Does the yoga have a role in management of neuropathic pain? Well, this particular article talks about some of the aspects of effect of yoga on neuropathic pain. So Iyengar form of yoga, it helps in spinal cord injury patients by building symmetric and asymmetric postures to gain flexibility, improve pain, and better awareness of the body structure. So yoga may help in the treatment of pain by altering the brain metabolism and neurotransmitters. So it has chemical effect on the brain. Insular cortex moderates the increased pain tolerance in yoga practitioners. So their pain tolerance improves by performing yoga. And yoga nidra meditation increases the endogenous dopamine, the happy hormone released in the ventral striatum, which also helps in alleviating the pain perception. And a 60-minute yoga session increases the gamma aminobutyric acid level as compared to the controls performing 60 minutes of reading. And this yoga session favorably affects the pain perception in the patients. So these were some of the findings or observations of this particular study about the role of yoga in neuropathic pain. Then this is a very interesting article published this year only by Deepak Chopra, who is an Indian-American motivational speaker, and he wears multiple hats. So this particular study, it's a long study, but the crux of it, what I could understand about this study, the authors offered yoga and pain pathway. They follow a lot of similar pathway in the brain, so that performing yoga can modulate the pain in a favorable manner in the patients or adults who are perceiving pain. So that's the crux of this story. As you can see in this, a very complex graph or interaction. Yoga, you are doing the movements. By doing the asanas, you are doing meditations. Then it is affecting the peripheral nervous system. And eventually somewhere it affects the central nervous system. Sensitization happens, and sensitization is a pain reaction. What happens? Pain, there is inflammation, there is catastrophization, which has some psychological component to it, and then there is a feedback loop. But what the authors was trying to suggest is that yoga and pain operate on many of the same sensory pathways, so making yoga a systematically effective form of pain management. And they did the mapping, functional system mapping, and overlaying the mechanism of pain response and yoga onto a map of core mechanisms required for a complex system, and it revealed a consistent overlap. So again, same point, re-emphasizing the same point, that authors suggested that yoga as pain management fulfills every requisite function to be considered as a complex system. So yoga can favorably modulate the pain in favorable manner. That's the crux I could understand out of this study. So coming to the last 2 or 3 slides, now we will conclude our talk. We know from the first part of the study that neurological disabilities are frequent, they are diverse and challenging, and the rehabilitation process should start soon. As I told you, nowadays acute rehabilitation is gaining a lot of traction. So patients getting rehabilitation in ICU once they are stable, and after recognition of disease, and it continues till integration of the patient into the society, which is the ultimate goal of all the rehabilitation programs. And there is converging evidence in favor of neurological rehabilitation program being cost effective. And there is enough concrete evidence in the last 2 to 3 decades, emerging in the last 2 to 3 decades, on the role of yoga and pranayama in rehabilitation of patients with neurological disorders. So what we need is a dedicated team and cohesive interdisciplinary approach to make the difference in these patients. So this is one poster which we made a few years ago, which we have put outside our OPD and NPD. So this is the ultimate goal of rehabilitation, from ICU care to community reintegration. As you can see, we have included all the aspects of services which we provide to the patients reporting to us in OPD, admitted in the IPD care, getting IPD care, getting treatment, getting physiotherapy, getting occupational therapy, using the recent techniques, urodynamic studies. So all these things put together, our ultimate goal is to reintegrate the patient and make them a meaningful person in the society again. So that is the eventual goal of rehabilitation. That is my message out of this talk. The rehabilitation is required, and there is a scope of integrating yoga and pranayama into the neurorehabilitation program to get an optimum outcome in these patients. Thank you.